Hello, everyone. Welcome. We're just going to give it a minute to let folks come in. We've got a lot of folks who are going to be listening in with us today. So we'll start in just a minute. Welcome, though. Glad to have you with us this afternoon. All right. As folks are still coming in, we'll do some introductions. Hi, everyone. I'm Lori Smetanka. I'm the Executive Director here at the National Consumer Voice for Quality Long-Term Care. We're glad to have you with us this afternoon for our webinar, which is going to be reviewing CMS's minimum staffing rule. Next slide, please, Libby. Just a few words about the Consumer Voice. I think you all know who we are if you're receiving our emails. Hopefully you all know who we are, but we are the national voice representing consumers and issues related to long-term care. And we do our work by advocating for public policies that support quality care and quality of life that's responsive to consumers' needs. We work to empower and educate consumers and families with the knowledge and tools that they need to advocate for themselves, because self-advocacy really is a really critical and important part of ensuring that you're getting the best care possible. We also work to train and support individuals and groups that empower and advocate for consumers of long-term care, including long-term care ombudsmen. And we work to promote the critical role of the direct care workers and best practices in quality care delivery that exists in long-term care facilities. So next slide, Libby. Just a few housekeeping items for today. So as you heard at the beginning, the program is being recorded. We do ask that if you have questions for the speakers, that you put your questions in the Q&A feature on your control panel, and we will take questions from there. If we have time at the end of the program, there is a lot to go over, but we're going to do our best to leave some time for a few questions. You can use the chat feature to submit comments, or if you're having technical issues that we'll try to help you with, but you can use the chat feature for that. When we close out, the pop-up evaluation will occur, so please take a moment to fill that out. The slides that you see today will be posted in a link in the chat, and we also will be posting them and the recording to the Consumer Voice website at the end of after the program is finished. So thanks so much for joining us today. So next slide, please. We're delighted to have with us three excellent speakers and policy experts. Sam Brooks, our Director of Public Policy, Richard Mollot from the Long-Term Care Community Coalition. He is Executive Director, and also Toby Edelman, Senior Policy Attorney at the Center for Medicare Advocacy. And I know many of you know Sam, Richard, and Toby, and we could not ask for a better team to lead us through these issues today. So as we get started for the program today, just a little bit of background. As you know, at the end of April 22nd, CMS issued a final rule establishing minimum staffing requirements for nursing homes. Under current rules that exist, nursing homes are required to have a licensed nurse on duty 24 hours a day, a registered nurse for only 8 hours a day, and otherwise only to provide sufficient staff to meet the needs of residents. Unfortunately, the vagueness of that standard of sufficient staff has led to really wide variations in staffing levels across the country, with some so low that it really defies expectations to think how residents were receiving any care, let alone the care they needed to attain or maintain their highest practicable levels of well-being, which is required under the nursing home reform law. Studies have consistently and overwhelmingly shown that higher staffing levels equate to better outcomes for residents, less abuse, and fewer deficiencies. And this is true for total staffing levels, which includes registered nurses, licensed practical nurses, and certified nursing assistants. And it's particularly true for the presence of RNs on duty, of registered nurses on duties. So for a long time, Consumer Voice and Richard and Toby and other partner advocates, as well as nursing professionals and others, have advocated for higher staffing levels, and in fact, minimum staffing levels, as well as a 24-hour registered nurse presence in nursing homes. So for 20 years, we've more than 20 years, we've been advocating for minimum staffing levels. And many of us rallied around a study that had come out 20 years ago, and more than 20 years ago, in 2001, which recommended at least 4.1 hours per resident day in a study that was commissioned by CMS. And that has been the targeted recommended staffing level that has had widespread support for more than 2 decades. So we really do recognize the need for much higher levels of staffing than we've currently seen in long-term care facilities. So 2 years ago, the Biden administration highlighted the need for more staff as part of its proposals for improving nursing home care. CMS then put out a request for information. They did a study, although we will say it was not as rigorous a review as the 2001 study. But they did a study, and they received more than 46,000 comments through the proposed rules that they issued last year to set a minimum staffing standard. And as I mentioned at the beginning, they issued the new standard in April of this year. So today we're going to walk through that final staffing rule. It does not set the standard that we wanted, as I think you've seen and heard from us, but it is important that there is a minimum below which facilities cannot go. And at Consumer Voice, we think it is the first step for working towards getting staffing that is absolutely necessary. And we're going to talk about that a little bit as part of the webinar today. So without further ado, I'm going to turn it over to Richard, who is going to start leading us through the elements of the minimum staffing requirement. Richard?
Thanks, Lori. That was a great introduction. Hi, everyone. My name is Richard Mollot. I'm with the Long-Term Care Community Coalition. Next slide, please. So I'm going to go over some of the basics of the new federal rule. One, as Lori said, the current requirements up to the implementation of this rule has been that nursing homes have to have an RN on a single shift 7 days a week. And then the other shifts every day can be made up by either an LPN, licensed practical nurse, or an RN. And what this rule does, I think one of the things that we, as Lori said, have long supported is that it requires that there be a 24-hour, 7 days a week presence of registered nurses in at least one registered nurse in a facility. And then there is a minimum overall staffing requirement of 3.48 hours per resident per day of overall staffing, including at least 0.55 hours per resident day of RN time and 2.45 hours per resident day of CNA time. And I think, thanks to Lori and Sam and Toby and thousands of others, including I'm sure many of you, as Lori said, CMS received, I think it was 46,000 plus comments. And originally CMS had proposed in its proposed rule last year, having 3 hours of direct care staff time comprised of only the RN component and the CNA component that I just mentioned, and that's here on the slide. And then, as Lori said, this was not a number that any of us could get around, and they did up to 3.48, which is, again, as Lori said, still low, but much higher. So it does show that our advocacy really can make a difference. And importantly, these minimum standards, the 3.48 hours, the 24/7 registered nurse time, does not supplant the longstanding requirement that Lori also mentioned, that nursing homes provide sufficient staffing. And the rules are really very strong on this and have gotten stronger over the years. During the Obama administration, the nursing home rules and the guidelines were revised. There's been a revision since then to the surveyor requirements, the inspector requirements, all of which add further clarity to the requirements for, if something is happening, like there's falls or there's pressure ulcers or high antipsychotic drugging rates, et cetera, that the surveyors should be looking at staffing. So a lot for us to think about and a lot for us to do and unpack with this rule. But here we are, again, it's 3.48. It is the absolute minimum which facilities will be required to provide. Next slide, please. So an important aspect of this from, I think, all our perspectives is that these requirements have not been implemented immediately. CMS is giving a lot of time for providers to come into compliance with this. And I think it's important to note, and Lori alluded to this a bit, the the staffing in our nursing homes averages about 3.67 hours roughly per resident per day of nursing staff time. So 3.48 is well below the current average. And frankly, too many of those nursing homes are providing crummy care. I think it's also important to note, as Lori had said, there was the federal study from 2001 that identified 4.1 hours per resident day as the minimum necessary just to meet residents' clinical, basic clinical needs. Not care with dignity, not appropriate infection control, as we've all seen is so critical after, through and after the COVID pandemic, just to meet their basic clinical needs. And the fact is that 25% of facilities consistently provide 4.1 hours or more of direct care staff time. The problem is, from our perspective, is that in the absence of strong enforcement of the sufficient staffing requirements and in absence of a minimum numerical standard, as we see introduced here, the facilities can do that, but it's totally voluntary. And 75% of facilities won't do it, but actually 25% do. And that's a sizable number. It's not just one or two facilities in each state, or or 10 facilities across the country. It is, 25% could do it. So it can be done. It just is unfortunately voluntary because of the lack of enforcement and the lack of clear numerical standards. So a little bit about the delayed implementation, which frankly we found very troubling. So there are a couple different aspects to this. One, and Toby will talk more about this, is that there is a facility assessment component to the federal rule. And as she'll discuss in greater detail, the facilities are now required to assess how much staffing that they need to meet their residents' care and quality of life needs. How much staffing must they have, and to bring in staff, to bring in residents and families, et cetera, in making those determinations. Facilities have 90 days with which to comply with that requirement. So that's really important, because what we're seeing is that facilities are going to have to be assessing how much staff they actually need. And as CMS itself said, that could very well be above 3.48 HPRD. It could be above 4.1 HPRD. So holding facilities accountable more strongly to actually meeting, understanding and meeting their residents' needs, I think we all agree is a really important component of this rule. However, in terms of the numerical requirements, it's kind of separated, as I note here, one for rural facilities and other for non-rural facilities. For rural facilities, the requirement regarding 3.48 hours per resident day and the requirement regarding 24/7 on-site RNs must be implemented 3 years after the publication date of the final rule, which just happened actually about a week ago. The requirement relating to a minimum of 0.55 RN and a minimum of 2.45 of nursing assistant HPRD must be implemented 5 years. So unfortunately, facilities are being given a huge amount of time to implement this. For non-rural facilities, it's a bit shorter. The requirement for the 3.48 overall and the 24/7 on-site RN has to be implemented within 2 years after the publication date of the final rule. And then that minimum specificity, of 0.55 RN, 2.45 CNA must be implemented 3 years after the publication date of the final rule. So just again, to shortly recap, for all facilities, they're going to be required to do the assessment, meaning that they are really taking substantive steps on an ongoing basis to identify what their staffing needs are and to meet those needs. But in terms of the specific numerical requirements in the new rule, which again are quite low and below the average that nursing homes are now providing, facilities are being given several years in which to implement that. Next slide, please. So I wanted to talk a little bit about how you can find information about your nursing home, or nursing homes in your community or in your state. So we publish, as many of you may know, we publish every quarter the staffing data for every single nursing home in the country that is in compliance with the federal staff reporting requirements. And here, if you just go to nursinghome411.org, our website, you can, on the front page, you can look down at the data and then scroll down to staffing. But we have every single quarter from when CMS first started requiring facilities to publicly report those data, or CMS started publicly reporting those data, which is the beginning of 2017. And so those data are all available here. The most recent data file is from the last quarter of 2023. So there's always a bit of a lag time. Next slide, please. And just to show you a couple of pictures of what you can see there. So you can compare via a map the different states, how the states are doing. You could click on any of the states and see some specific information about state averages. Next slide, please. And then this is again, this is what every single quarter looks like. So you can see the national averages on the upper right. You can see we have a chart with the states and their averages for total nurse staffing, their ranking, their percent of providers that are above that 4.1 HPRD level, percent of staff that are contract in the state. So you could compare states, and then you could download the nurse staffing information for the quarter, non-nurse staffing, which includes medical director, OT staff, PT staff, recreation staff, et cetera, summary data, turnover and weekend data information, which is really important because the extent to which a facility has turnover or disparities on weekend staffing can be very important, et cetera. Next slide, please. And this is just a sample. I know it's hard to see, but just to give you a sense so it's one file, but you can click on the upper left-hand side. You can look at it, filter by state, as I've done here for our home state of New York. You can click on the CMS region if you want to see what's going on in your region. And then within the file itself, you can search for a specific provider. You can identify one city or more than one city that you're interested in, or one county and more than one county that you're interested in. And then there's a lot of data to the right, which I didn't include because it would make it really small, but we have the total nurse staffing hours per resident day, direct care nurse staffing hours per resident day, and then broken down by RNs, LPNs, et cetera. So if you're an ombudsman who's looking in certain counties to see what's going on, you can select your counties, or if you're a state ombudsman, you could look at the whole state, et cetera. And again, those data are available. I see people are asking some questions, and thank you, Lori, for answering. Those data are on our website, nursinghome411.org/data/staffing. And it's pretty easy to find. If you just go to nursinghome411.org, we have the data files right there. Next slide, please. And then lastly, if you wanted to find data on a specific date, and I was actually just talking to a family council about this before this program, you can find in the underlying database, which we use every quarter to do the averages, but every quarter, this is what comes out. It's over 1 million lines of data, but you could actually just open up the data set, payroll-based journal, daily nurse staffing, as I've shown here for the quarter, and you could search for your facility, you can search for your state, et cetera, and then you could see what's going on specific days. So if you have concerns about what's going on with your facility, say on weekends or on certain dates, you can go back and find it there. And I have the link below there. This is from the data.cms.gov website, and it's, again, the payroll-based journal, daily nurse staffing. Next slide, please. I think that's it for me. Great, thank you. And passing this on to Sam, I believe.
Thank you, Richard. That was a wonderful recap. Hi, everyone. I'm Sam Brooks. I'm the Director of Public Policy at Consumer Voice. I am going to be taking you through the numerous waivers and exemptions that CMS has offered facilities to avoid compliance with the new staffing standards. I warn you, it's very complicated and you're not going to get it just by me telling you. So as you can see in the chat, and at the end, we're also providing a summary, a link to a summary. You're going to want to look at these things yourself. But nevertheless, we will do our best to walk you through the various waivers and exemptions. Next slide, please. So CMS has built into this rule numerous opportunities to allow facilities to get waivers of the requirements and exemptions for the requirements. And you will see, in fact, CMS in some instances has estimated that 25% of facilities will get waivers. In the preface to the rule, they estimated that 60% of facilities could get an RN waiver, just based on geography. Unfortunately, a lot of these waivers are going to go to the worst performing homes, because this is really what this rule addresses, are the most poor performing homes in the country. To start walking you through the process for the the RN waivers is complicated, and it's complicated by the fact that there's existing statutory waivers. There's two existing statutory waivers. One that allows facilities to avoid providing licensed nurses, which are RNs and LPNs on a 24-hour basis. And another that waives the requirement that a facility provide RN services for more than 40 hours per week. These are in the law. They could not be changed by regulation. But we'll see that CMS is taking advantage of them to allow lots of these new rules to be waived. In addition to these existing statutory waivers, CMS has created additional exemptions related to the new staffing requirements. Next slide, please. So I'm really just going to take you through the regulations and what they say. CMS created a new set of regulations that occur in the waivers and exemptions begin at in the Code of Federal Regulations. Citation is at the top. The first waiver is going to allow facilities to avoid complying with the 24/7 RM requirement, the licensed nurse provision of licensed nursing, say licensed nurse practitioners, and or the 0.55 RN hours per resident day requirement. So this waiver will allow it could allow complete avoidance of these new requirements. And this is generally what the waiver says. The state may waive the requirement that a nursing facility provide these services if it demonstrates certain things, that it has been unable to recruit appropriate personnel despite diligent efforts. The state determines the health and the safety of the residents is not endangered. Which is hard to imagine since we know that RNs and licensed nurses play such a critical role in healthcare, but nevertheless, that's one of the requirements. An RN or physician is obligated to respond immediately to telephone calls from the facility. So if you can't have someone there, you got to have someone being able to answer a phone call. And notice of this waiver must be provided by the state agency granting the waiver to the long-term care ombudsman and the protection and advocacy system, and to the facility residents and their representatives. So in order to qualify, if you meet all of these requirements, you will need to provide notice to those organizations and to residents. This waiver is subject to annual state review, so it can go on forever. But it has to be reviewed each year by the state. We'll get a little more into how these things are gauged a little later in the slides. Next slide, please. So this, again, is creating a regulation that incorporates the statutory waivers. And this is the waiver that a facility provide an RN for more than 40 hours per week. So they would only have to provide 8 hours a day for 5 days straight under this waiver. The secretary, so this is a waiver that's determined by the federal government, may waive the requirement that a skilled nursing facility provide RN services for more than 40 hours per week if the facility is in a rural area and the supply of skilled nursing services is not sufficient to meet the needs of the individuals living in the area. The facility has at least one full-time RN who is regular on duty 40 hours a week. The facility only has patients who has indicated by their physicians that do not require RN or physician services for a 48-hour period. So that would be on the weekend. Hard to think of a nursing home that has residents that wouldn't require licensed nursing on the weekend, but nevertheless, that is one of the requirements. And the facility has made arrangements for an RN or physician to spend time at the facility when the regular full-time RN is not on duty. Again, there's some waiver requirements here, some notice requirements. Again, the state long-term care ombudsman program and the protection and advocacy system have to be noticed, and the facility has to provide notice to residents and their representatives. This waiver is subject to annual renewal by the secretary. So you can see here, before we get on to the new waivers, these aren't even the newly created waivers. Facilities are going to have a couple opportunities already to avoid this 24/7 RN requirement and the 0.55 RN requirement. Next slide, please. So under 42 CFR 483.5H, CMS has created a complete new set of waivers. And these are called hardship exemptions and so these are supposedly going to be granted to facilities who are experiencing hardships. Under these waivers, they can, under these exemptions, facilities will be able to avoid compliance with the total minimum staffing, the 3.48, the NA and RN HPRD, either or, and or the 24/7 RN requirements. So the secretary may exempt a facility from meeting one or more of the minimum staffing nursing requirements and 8 hours of the 24/7 RM requirement. So under this waiver, they can't get the whole RM requirement waived, but only 8 hours. But all of the other requirements can be waived. There are 4 criteria to qualify for a hardship exemption based on location, good faith efforts to hire, a demonstrated financial commitment, and disclosure of exemption status. And we're going to go through those one by one. Next slide, please. So location. The good news is CMS took out some of the really poorly suggested waiver requirements in the proposed rule. Nevertheless, they're still going to use location as one of the factors to grant an exemption here. So the facility is in an area where the supply of the applicable healthcare staff is not sufficient to meet area needs. And this is determined, and again, I'm sorry about this, you're not going to memorize it, but it goes over more in depth in our summary, and you'll be able to get these slides. The supply of staff is determined to be not sufficient if the provider to population ratio for the nursing workforce is at least 20% below the national average. So it's a complicated calculation here that relies on Bureau of Labor Statistics and Census Bureau data. Essentially, what they're going to do here is they're going to look at a specific area, then rely on Bureau of Labor Statistics to gauge how many CNAs, LPNs, or RNs are there, and then look at the total population and find what the ratio is, and then compare that to the country. Again, this is a complex thing that we walk through in our summary, but nevertheless, that is here for you to look at now. The provider to population ratio is evaluated for each requirement. So if it's the total HPRD, it's the total of the NA, the CNAs, the LPNs, and the RNs. This is really an idea. CMS was obsessed with the idea that rural areas were not going to be able to meet these requirements, despite the fact that their own staffing studies showed that staffing was almost identical, really, in rural and urban areas. And when we look at it, we do not see any pattern of staffing challenges any more pronounced in rural areas than we do in urban areas. But this is, I think, a compromise CMS thought they were making. Next slide, please. So good faith efforts to hire. CMS is going to say to the facility, you have to demonstrate an inability to recruit and retain appropriate personnel despite diligent efforts to do so, including offering prevailing wages. Facilities will have to post or document that they posted jobs, made offers, documented average local wages, and share their staffing plan. Importantly here, it's prevailing wages. We know that the average CNA wage is $17 an hour across the country. So it's not that they have to offer better jobs. They just have to offer the wages they've been offering the whole time to meet this requirement. There's no requirement here that they create better jobs, provide better training, only that they're doing the de minimis when it comes to these good faith efforts to hire. Next slide, please. Demonstrated financial commitment. The facility will be required to document the amount of financial resources it spends on staffing relative to revenue. That's all they'll be required to do, is to show how much they spend on direct staff compared to how much money they make. There's no bar, there's no cutoff that say it's 50 or 80% or 90%. You just have to show it. What that does, it's unclear to us, but nevertheless, they will be required to show how much they're spending compared to their revenues. Next slide, please. Some good things here. If there is a silver lining in this, there are some disclosure requirements of exemption status similar to the ones before. If you receive an exemption, in order to receive it, you're going to have to post it in a prominent location in the facility in a manner that is accessible and understandable by residents and representatives. Exemption disclosure must include the extent to which the facility does not meet the minimum staffing requirements and the time frame during which the exemption applies. So they'll have to say we're receiving an exemption from the total HPRD or the NA or the RN or a combination of those, and how long that applies. Again, CMS has also said, and we hope they do this, that they will post it on Care Compare, but these need to be, and notice will need to be provided to each current and prospective resident, and also sent to the state long-term care ombudsman program. So it will really need, we're really hopeful that the notice requirements and the disclosure requirements will help incentivize compliance with the new regulations. Next slide, please. Also, there are facilities that are ineligible for exemptions. Facilities ineligible for exemptions are special focus facilities. These are particularly poor facilities. The good news for industry is there's only 88 special focus facilities in the country out of about 15,000 nursing homes, so this won't apply to many facilities. Facilities cited for immediate jeopardy, widespread or pattern of insufficient staffing with resultant resident actual harm. These are technical terms, but these are citations that harm or rise to the level of what they call immediate jeopardy because of staffing, and facilities that have failed to submit payroll-based journal data. So if you're one of these categories, you will not be eligible for an exemption. Next slide, please. So some of the details on these exemptions and waivers. Exemption eligibility will be determined automatically when a facility is found to have violated the staffing rule. It sounds like what will happen if a facility is cited during an annual survey, CMS will just automatically determine whether they're eligible for an exemption. This is one of the things we're very concerned about. Documentation of eligibility for exemption is not mandatory. The regulation says, but it must be provided when requested. We are very concerned that CMS does not have the capacity to process thousands and thousands of exemptions, and this will just become sort of a checkbox cookie cutter type process that real documentation may not be required. Exemptions last 1 year, then they can be redetermined. There's no limitations on waivers and exemptions. So some residents under this model will never feel the benefits of a minimum staffing standard, potentially. And CMS cites regulatory flexibility. Facilities may apply for whichever waiver or exemption they choose, so they're going to get many bites at the apple. Next slide, please. Consumer voice in our comments, and I think many in your comments, oppose waivers and exemptions. CMS, as I said earlier, has estimated 25% of facilities will qualify for these waivers and or exemptions. Little evidence, as I noted, support rural homes are faced with more pressing staffing problems than non-rural homes. Waivers and exemptions enshrine inequities in care. Many residents, as I said, will never experience the benefits of a minimum staffing standard. There's going to be residents across the country that are receiving sufficient care and residents that are not. And we all know who disparities and inequities in healthcare fall upon. So we're very concerned about that. Critically, CMS is still allowing facilities with these exemptions and waivers to continue to admit new residents, therefore exacerbating the problem. Despite not being able to meet just the barest needs of residents, the most minimal needs of residents, they're still going to be allowed to admit residents and increase that gap between sufficient staffing and the number of residents. And as I said earlier, due to regulatory challenges, we're really concerned that these waivers will be granted with little scrutiny, and that these will, for some folks, just be automatically granted. Next slide, please. One of our concerns, there's no financial accountability for how the nursing homes spend money. The constant refrain is there isn't enough money to pay for staff. We can't find staff. But as Richard pointed out, over a quarter of facilities provide more than sufficient staffing, particularly nonprofit homes. And this whole waiver and rule are based upon a Medicare and Medicaid funding system that allows nursing homes to siphon away billions of dollars to related parties. This money is siphoned away from workers and residents, and there's no effort here to hold nursing homes accountable for how they spend that money. So the whole rule is really built upon a system that lacks accountability and lacks a requirement that the billions and billions of dollars that we provide to nursing homes are spent on direct care. And we're going to continue as advocates to fight for financial accountability. It's so critical. So much of the needed reforms that we need are undermined by the idea that there isn't enough money, that there's no one to hire. And until we really have transparency, we're going to continue to get rules that are hedged over by lots of waivers and exemptions and other issues. So I've gone on long enough. Again, that's a lot of information to digest, and you'll see that we have a nice summary at the end. I'm going to pass it on to Toby. Thank you.
Thanks, Sam. Richard and Sam have been talking about the numerical requirements in the new staffing rule, the 3.48 hours per resident day of nursing staff, the 24-hour RN coverage. These rules are delayed, as they said. They don't go into effect for 2 to 5 years, depending upon whether the facility is rural or non-rural. But what I want to talk about in my short time here is a separate part of the final rule, and maybe it gives us a little bit more hope, and that's the facility assessment process. Next slide, please. This part of the final rule goes into effect August 8th. It goes into effect 90 days from the day the rule was published in the Federal Register last Friday. It applies to rural and non-rural facilities alike, and it doesn't include all this waiver and exception language. It's a requirement that will be in effect very soon. Next slide, please. You can see there's a modification to the nursing services regulation. The requirement 483.35B3 now includes some interesting language saying compliance with these staffing numbers should not be construed as approval for a facility to staff only to these numerical standards. Facilities also have to make sure they have sufficient staff as determined by the facility assessment process. So what I will be talking about and what I have the language from the preamble and stressing is that facilities have a separate independent obligation to make sure that they staff sufficiently to meet the needs of their own residents. And what CMS says throughout the preamble is that in many instances, that will be higher than these minimum numbers, which aren't even going into effect for many years. Next slide, please. So there are different standards. There are the number standards, and there's the facility assessment, and each of them matters. So regardless of whatever else happens, the facilities, unless they get waivers and exceptions, they have to meet the 3.48 and they have to meet the 24/7, but they also need to make sure that they do a facility assessment and provide higher staffing levels if that's what their residents need. Next slide, please. The preamble language says this. If the facility assessment indicates a higher HPRD for either total nursing staff or an individual category, the facility must comply with that determination in order to have sufficient staff. So we just want to see this over and over again in the preamble. The numbers are the minimum, but if the facility does an assessment properly, it may and many will have to provide higher staffing levels than those minimum numbers. Next slide, please. So in addition to this section on facility assessment, which is now given its own section in the rules, 483.71, facilities assessment is referred to 3 other places: in the QAPI rule, in infection control, and in, interestingly, the training requirements, which says facility must determine the amount and types of training necessary based on the facility assessment. So that seems like a very important point. If the facility assessment shows that there's a need for more training for staff, then they're supposed to be providing it. Next slide, please. Now, the facility assessment requirement is not actually new. It was put into place in 2016 by the Obama administration, which decided it wanted to do a comprehensive review of the requirements of participation for nursing facilities. Hadn't been done in 25 years. Many of us were calling for staffing ratios. The Obama administration did not do that, but it said, instead, we're putting in place a facility assessment requirement. Every facility has to conduct and document the facility-wide assessment. They have to determine what the resources they must have to provide care for the residents they serve. The assessment has to be reviewed, updated annually, and as necessary, and whenever the facility plans for a change in the population or services. So if the facility is adding dialysis as a service, it has to do an assessment, make sure it has the proper equipment, the proper staff to be able to provide dialysis. If they're going to serve bariatric patients that they've never done before, got to do a new assessment. So any change in the residents or in the services they're providing, they have to do an assessment. This is from 2016. And the assessment has to address the population, their resources, and risk assessment. Next slide, please. In 2016, the preamble to those final Obama regulations described the facility assessment process, and it was a pretty good process. It's not bad. It really says what we would want a process to do. Next slide, please. In addition to the preamble, of course, what the federal government does is issue in the State Operations Manual Appendix PP, which gives more information to surveyors about how to determine compliance with the requirements of participation. So Appendix PP had a lot of information about the assessment process. Next slide, please. And this is some good language in here about what they're supposed to do. Make sure they have sufficient number of qualified staff to meet each resident's need. It's a competency-based approach. We want to meet the psychosocial needs as well as the physical and functional needs. All very good language. Next slide, please. The problem with the facility assessment process that was put in place in 2016 is that every facility was able to choose how it wanted to do assessment. And as a result, it wasn't treated very seriously by facilities, even though CMS said it was important. And it was almost never cited in the survey process, very limited number of deficiencies cited. It had its own tag, F838, but it wasn't cited. And even more significantly, there were hardly any deficiencies cited at a level of harm or immediate jeopardy, where we would be more likely to say any kind of financial penalty. So in a 3-year period, there were only 9 facility assessment deficiencies that were called harm or jeopardy. So obviously not much happened as a result. Next slide, please. So 2024, we have facility assessment again. It's a new requirement, 483.71. The language says the assessment has to use evidence-based, this is new language, evidence-based, data-driven methods. The other language that's new is that the assessment has to be consistent with and informed by individual resident assessments. Most of the language repeats what was in the prior requirement for facility assessment, which was included in 483.70, which is administration. It had a paragraph E, which was facility assessment. So 483.71 copies that language, says now the assessment has to use evidence-based, data-driven methods and resident assessments, and language from the State Operations Manual, Appendix PP, which was guidance language, now becomes mandatory language in the final regulation. Next slide, please. So as before, facilities have to conduct and document a facility-wide assessment to determine the resources, including staff number, competencies of staff, and the skill sets of staff that are needed to provide care to the residents that the facility has to be reviewed and updated as necessary and at least annually. It must include the leadership and direct care staff. And what's new here in 2024 is it must also solicit and consider input received from residents, resident representatives, and family members. That's new, and it's an important opportunity for us to provide input about staffing levels to the nursing home. Now, we could ask, we should be asking facilities what their process is and how we can all get involved, but it is specifically in the regulation now for the first time that they must solicit and consider input. That's an important change. Next slide, please. The preamble to the final rule states repeatedly, and I really can't stress this often enough, that the facility assessment process is not only enhanced, but it's a separate standard, and facilities need to do it. They need to do it carefully, and they need to, if it says more staff are needed, that's what they're supposed to comply with. Next slide, please. You can see there's language, the sentence right there. This is the preamble. That will require higher staffing than the minimum requirements. Important language. Next slide, please. The preamble in several places, and I quoted the language and tell you the page in the Federal Register so you can find it, where CMS says many facilities are going to need to staff at higher levels than the minimum numbers based on the facility assessment. So when the nursing home says to you, well, we have 0.45 registered nurse, that's good enough. No, it's not good enough. If the facility assessment says your residents say they need more, then the facility is obligated by the facility assessment process to do more, to have more. Next slide, please. CMS explained in the preamble that it had a separate regulation. It designated facility assessment as a new section 483.71 to stress the importance of the facility assessment and to complement the minimum staffing numbers. It's an addition, it's more, it's important, and it needs to be done. Next slide, please. The preamble also makes clear, and I have the language quoted here, that the facility assessment is where resident acuity has to be addressed by the facility. The numbers that Richard and Sam talked about are numbers that everybody has to meet. But the facility in its assessment process is supposed to look at its own residents and say, what do these residents need? What do their assessments say they need? That's what the facility is supposed to do. Next slide, please. And here's just more preamble language that's very good. It's facility assessment must be used to develop and maintain the staffing plan or the plan to maximize recruitment and retention of direct care staff. Very important language. Make sure you have it in your hand when you go talk to the facility. Next slide, please. So when I read all of this in the regulatory language and in the preamble, I was pretty excited and hopeful. CMS referred to facility assessment 172 times in the preamble. It says it's going to have a template for facilities. CMS stressed in the language of the rule and in the preamble, which I quoted above, that the assessment process will show that many facilities need to staff at higher levels than the mandatory minimum levels that Richard and Sam talked about. And CMS almost doubled the cost of, more than doubled the cost of the time and the time for conducting facility assessment. In the proposed rule, it said it would take 22 hours of staff time. In the final rule, they say 62 hours, much more significant. And the facility assessment process, as I showed before, is referred to in QAPI, infection control, and training requirements. Next slide, please. However, as positive as I think this is, I'm concerned about how CMS is actually going to implement this requirement. We know that the federal government doesn't provide care directly. That's what facilities do. But the federal government's responsibility is to say what the requirements are for facilities, the requirements of participation you must do. This is what you must do if you want certification and Medicare Medicaid money. It must say how surveys should be conducted to determine compliance, and then it's supposed to impose penalties for non-compliance. Those are the federal responsibilities. CMS does not right now seem to be doing those tasks for the facility assessment process, and it's coming up quick. August 8th is going to be here before we know it. CMS has promised that it will do a template, but it said it would not be prescriptive and identify the specific evidence-based, data-driven methods that facilities should use. Now, I know our comments and other advocates' comments suggested that CMS designate a facility assessment process. Here's a method. Professor Harrington and her colleagues did a very excellent job of explaining how to come up with the staffing using all kinds of data. The Medicare Skilled Nursing Facility Part A reimbursement methodology has different amounts of nurse staffing based on the needs of the residents. We suggested that CMS pick one of those, or tell facilities you can pick one of either of those, or another recognized evidence-based, data-driven methodology. Next slide, please. But CMS didn't do that. It said it's taking that under advisement for another day. Then we get to the survey process. Well, CMS says in the preamble that surveyors can't determine the quality of the facility assessment, but they can determine that the facility is not in compliance if it didn't contain all the requirements in the new regulation, and if it failed to determine a direct care staffing plan consistent with the facility resident acuity levels. Unfortunately, at least at this point, CMS doesn't seem to be planning on training surveyors specifically in how to determine compliance with the facility assessment process, or requiring facilities to look at the facility assessment process in every survey they conduct, which I think is essential to me, because CMS says in the preamble, when facilities do this, many of them will need to staff at higher levels. But the survey doesn't seem to be doing that. And also CMS does not seem to be planning on any specific enforcement guidance about this using the standard enforcement system. Next slide, please. So what CMS is saying is that it plans to use the standard survey and enforcement system to impose penalties and remedies for non-compliance with standards. So that means they have the usual substantial compliance standard, and they have administrative appeals and judicial appeals. Now, CMS alludes to more data-driven enforcement, including use of the payroll-based journal, but has not committed to base deficiencies on payroll-based journal information that's submitted by facilities, although many of us had encouraged them to do that. Next slide, please. So here is the language. They can use informal dispute resolution, administrative, judicial appeals. We're having the same staffing standard. Next slide, please. Now, what many of us had recommended in the proposed rules, which CMS has not yet adopted, is that there be automatic civil money penalties when the PBJ data show non-compliance with numerical staffing requirements. President Biden's reform agenda said we should do things off-site, base some deficiencies on information that is presented, not only on-site surveys. Well, CMS didn't accept that recommendation. And we also believe that there should be automatic bans on admissions when a facility does not meet the staffing requirement or doesn't have sufficient staff. And as AARP wrote in a blog post last week and in letters to members of Congress supporting the final rule, but saying, you know, if facilities don't meet the staffing requirements, they should not be admitting new residents, and that seems right. If they don't have enough staff to provide care to meet the standards that the law has, that the law is setting, then they shouldn't take new residents. That just seems pretty obvious and like an important point. Last slide. And so my conclusion is that this is a challenge for us. The facility assessment process is a challenge because CMS hasn't done as much as we would like yet, but it's also an opportunity. And I think we want to try and do our best to make implementation of this process live up to the promise of the regulatory language and the promise of the preamble. We should take all opportunities or make them available to us to provide input on staffing to facilities as they move forward doing their facility assessment process. And our goal really needs to be to ensure that facilities staff adequately to provide good care for their residents and go beyond the minimum, which will be what many residents need. Thank you. Sam, back to you.
Thanks, Toby. That was a great summary of a very complicated issue. Quickly, there was another provision in the final rule, and many of you might have recalled it from the proposed rule on Medicaid transparency. CMS is now going to require states to annually report by facility the percentage of Medicaid payments spent on compensation for direct care workers and support staff. This is for nursing facilities and intermediate care facilities for individuals with intellectual disabilities. Their direct care workers and support staff are defined differently, but the idea behind this is to gauge how much money is being spent on direct care through Medicaid. Really, it's like kind of a sliver of a picture of how nursing homes spend their money. This information will be required to be posted publicly by the state in a clear and understandable way, and CMS will also report this data on its website. So we want to move quickly. We're almost at the end here. Next slide, please. Next slide. Wanted to share some resources with folks, and I'll talk about this one, and then Richard, you can talk about the next one. We released our final summary of the final rule today, which goes through each bit and in a little more detail than today, and you can access it at that link. We hope that that's helpful. And Richard, I'll turn it over to you for your slides.
Great, thanks, Sam. So here's again links to the where you can find staffing data, on our website, nursinghomes411.org, and the daily staffing data for each day of a quarter on the CMS website. Next slide, please. Then I wanted to mention, we actually just finished up last night a new fact sheet on how residents and families can provide input to their facility's staffing assessment. It provides information on what the requirement is for the facility, as well as tips for residents and families and resident and family councils. So we strongly encourage you to participate in that and to hold your facility accountable for listening to you. Thanks, Sam.
Oh my goodness, that was
Rich.
a lot of information to be shared. As you could see, the rule has a lot in it. There are sections that are complicated, and we are at just about the top of the hour. You can see the summary information that's included in the links. As I mentioned, the recording will be available here. I think as we close, you know, there were questions about like, what is this really going to mean for residents, and how do we need to continue to advocate for better care? And I think that that is something that we are going to have to be doing. Our work's not done, obviously, because you know these rules came out. They certainly weren't at the levels that we wanted, but even if they were, our work would not be finished. So you know, I think as we think about the advocacy that's needed, think about the presentations, you know, that you heard today. Look at the postings in your facility, where the facilities are required to post the staffing levels by shift, by type of person that is actually providing services, how many staff are available. So you should be asking about that. That needs to be posted in a place where you can see it and is very accessible. Ask your facilities about being involved in the assessment process, and how are they going to include residents and families in the assessment process. Check your facility staffing levels, not only in the postings, but look at what's available on Care Compare. Look at the data that Richard and his group provide, so that you know what information is there. If they're not meeting the standards, you know, call them on it and ask them why not. And, you know, file complaints with your licensing agency if there continue to be care concerns about the care that's being received due to low staffing, and make sure you're documenting evidence. And Toby, Richard, and Sam, do you have any other suggestions or recommendations for folks as they're advocating?
I just want to say one thing. There's efforts right now to derail this in Congress. It's likely going to manifest itself. There's already bills out there to stop the staffing standard. While it wasn't the standard we wanted, it is a standard and we can build upon it, and it's just a basement. So if you're talking with your legislators, if you're talking with policymakers, you need to let them know that you support this despite any of the flaws that you see in it. Otherwise, this could be a one-shot deal, and we could never have a staffing standard at all. So I encourage you to speak out and tell your legislators and tell policymakers that you support a staffing standard. Thanks.
Yeah, and Lori, I also think that the facility assessment, because it goes into effect in August, they've got to do this now. We need to treat it seriously. I mean, CMS treats it quite seriously in the preamble and in the regulation, and we need to make it as much as possible the reality for people, that facilities have got to figure out what their residents need and provide staff appropriately.
Absolutely. So this is the first step for us in terms of sharing more information and advocacy with you all around continuing to work to achieve quality care for every resident in long-term care facilities. You'll be hearing more from all of our respective organizations as we move forward and as we continue to be working and advocating on these issues. Thank you so much for joining us today. And Toby, Richard, and Sam, thank you for walking us through the rule and your excellent presentation and resources. Have a good rest of the day, everyone.
Bye.